It's worked. I'm live on Facebook, and I'm late. I know I'm late, but I'm actually very, very happy to be here tonight because I have officially actually been banned from Facebook for 7 days, and I'm still within that 7 day period, but they have obviously let me back. So I want to say, if you're there watching Facebook, thank you for letting me back on early, and for lifting my ban. And I'm very sorry that I yet again breached the Facebook guidelines. I think I've narrowed it down. I think the problem is the nipples. I think the nipples are the problem, and I now realise that, and I'm going to do what I've seen other people doing when they post pictures and they put silly little emojis over the nipples and they put flowers and all sorts of things over the nipples. I've got to say, I don't like it. I accept that for me, I obviously deal in these sorts of images all the time, if you like, and I see these sorts of things, but I accept that it can be maybe a bit offensive. I mean, the picture that I got banned for, I put on the private group, the private Facebook group. It wasn't even on general Facebook. It was on the closed group for people who've been to the clinic. And anyway, I'm sorry, Facebook, that I put that picture on, and I will cover up the nipples in future. And hopefully I will be able to avoid a I can't reply, Ruth. I was going to say hello. I just have to like that. Hopefully I will avoid future bans. But anyway, I'm very, very pleased that I'm back on, because I thought I was going to didn't know what I was going to do today. So back on Facebook, and I will be very sure that I don't breach the terms and conditions again. It's the third time I've been banned. First was 1 day, then 3 days, and the last one was 7 days. So I'm a bit nervous. I keep on doing these pictures. The problem is it's the nature of the job that I'm in, but I've got to be a bit careful with the photos that I put on. I accept that, and I will try and be more careful and try not to be inflammatory. So that is great. It's great to be here. It's great to be alive and to have freedom to like posts and put stuff on Facebook. And I'm just so happy that oh god, this is a real lag on these I was going to put some kind of happy mask on, but there's such a lag on it. That's the problem. If they came straight away, you'd know what we'd be doing, but they do. Oh my lord, look at them all. So we've got some questions. Obviously, we've got some questions which I am going to go through presently. Oh god, sorry. Oh god, my earpiece got. No, what's that? Oh god, which my sorry, I try to put a mask on. You can't tell what they are. So I'm going to go through these questions presently. So tattoo, jump in straight in. Well, it's not straight in, is it? Sorry, I'll get that off. Tattoo. How long between sessions for a serial excision? Nope. Between a serial excision of a tattoo. Well, a serial excision, has that just paused? Oh yeah. Oh yeah. Oh yeah. This would be good in the summertime, wouldn't it? Serial excision of tattoo. So serial excision of tattoo means that you how do you get them off? Means that you take it's a big tattoo, and you take a piece of it away. Then you still have a tattoo with a scar. You close it tightly, and then after a period of time, once the skin has had time to adjust, it no longer feels tight, so that you can go back and take another pice away. That's a serial excision, and that's what you do for big lesions. And commonly we use it for tattoos that are too big to take out in one go. And there's always a balance between, people always want to have it out as quickly as possible. But you have to let that scar soften, and it's a bit of a paradox really, because you want to get that scar to soften as much as possible, and then you hit it again and give it another scar. So in answer to the question how long, for me personally, I normally wait a minimum of 3 months between sessions, and sometimes you're going to need to do 5-6 sessions, so that means it can take a long time. It can take years to remove some of these bigger lesions, because I need to wait at least 3 months between them. I'm just seeing what I've gone down the bottom here. But it, I don't know what I've done there. It is, if anything, if you wait a bit longer, it'll be better because it'll be softer and it'll be easier to close. So, the simple question, to cut a long story short, is 3 months away between sessions. But if you wait longer, you're going to have more, the skin's going to be more relaxed if you wait longer. And so potentially you could get more out if the skin's more relaxed. And so you could potentially have fewer sessions if you waited longer. But as I say, it's a balance between the fewer sessions, but you want to have them closer together to get it over with quicker. I think I made that quite clear. Hope I have. If not, then let me know and I'll try and make it clearer in another fashion. So lesions, GA or LA? I don't know. You see, I don't know what are lay terms and what are medical terms. Are GA and LA lay terms, or are they medical terms? Do people? I've just got all these. I don't know. If anyone's leaving any comments, I'm not looking at them because I'm looking at all these various. I don't know what they are down the bottom. Time. So anyway, GA means general anaesthetic, LA means local anaesthetic, and usually lesions means a mole or a cyst. Oh God, oh my God, we don't like that. We'll get that off. A mole or a cyst, and that's usually done under local anaesthetic, which is you stay awake, injection around the thing, and then we cut it out with you sort of awake, a bit like being at the dentist. And it's rare to need a GA. GA means you get put to sleep for a lesion, but we have had some, I think we've had some recently which are quite big or recurrent, which means they've come back after previous excisions, there's scarring around the area. Or the other thing is in young people, then you would maybe think more along the lines of doing a general anaesthetic, so you don't want to traumatise anyone. There are more risks associated with the general anaesthetic, although the risks are pretty rare or pretty low for these smaller procedures, because the anaesthetic will be a short anaesthetic, and there's more costs associated with the general anaesthetic because we wouldn't be able to do that at the clinic. If you had a general anaesthetic, you'd have to go to one of the hospitals to have the general anaesthetic, and obviously you get an anaesthetist involved, so there is implications in terms of that. But the what was the question? I don't know what I've just written. GA, I think the question is what would make us decide between a GA and LA, I think. So the thing that would make us decide is, one, patient preference. So if you really don't think you'll be up for a local anaesthetic, then we can consider a general anaesthetic, given that it would be more expensive, and also general anaesthetics done more as like a day case, which means you're usually just in the hospital for the day, but you are in the hospital for most of the day, because you have to come in, you have to get prepped and all that sort of thing. You have to be starved for 6 hours before. There's no starving associated with a local anaesthetic. You normally have to get into a gown and all these bit more of a palaver, and then they have to make sure that you're comfortable after the anaesthetic. Sometimes you can feel a bit groggy, a bit sick, so you have to make sure you've passed urine and had something to eat and potted around. So you're normally on the ward about 4 or 5 hours after the anaesthetic. So you're in most of the day if you have a general anaesthetic, whereas a local anaesthetic you sort of walk in, walk out. So there is more associated with the general anaesthetic. But if it's a very big lesion, if it's deep, then it's probably going to be more comfortable to do under a general anaesthetic. I recently did actually quite a big lipoma on the side under a general anaesthetic, actually. So so if it's a big lesion, if it's quite deep, and also if you think you'll be worried and you're not going to enjoy a local anaesthetic, then we can do it that way. And then there's a halfway house between the two, which is a local anaesthetic with sedation, which again would have to be done at the hospital. Again, would involve an anaesthetist, so there would be cost implications. In fact, the cost would probably be the same as having it underdone under a general anaesthetic, but so local anaesthetic and sedation is an option. Yeah. Okay. Thank you. All right, Freddie. Thank you. Yeah.
Where's Mum, Dad?
Okay. This is professional.
Where's
This is a professional thing I'm doing for work.
Where's
all right.
Mum?
I guess she's upstairs. Can you just go and have a look, please? Right. Thank you. Yeah, Freddie, please. Just. Right. Sorry about that. So yeah, I think that's answered that one. So so local anaesthetic sedation is sort of a halfway house between the two. I guess the memo didn't go out that I was doing this in here today, so I'm sorry about that. But I will discipline that child severely as soon as this is finished, and it won't happen again. Although it has happened before, hasn't it? So yes, so general anaesthetic, if the patient is really worried about a general anaesthetic, or the lesion is very large. But I have to say, a lot of people are very worried about local anaesthetic. But if you can do it under local anaesthetic, it's better to do it under local anaesthetic as a rule. I think local anaesthetic, there's a lot to be said for it. You can do quite a lot under local anaesthetic, and most of the lesions that we remove are under local anaesthetic. Does sting a little bit, but once the local anaesthetic's in, you just sort of feel touch and movement. You don't feel anything painful, and so it is, generally speaking, for lesions, moles, cysts, things that aren't too deep underneath the skin, then local anaesthetic is usually the way forward. But general is an option. Good to have options. Always good to have options. As a saying, if all you've got is a hammer, everything looks like a nail. So because we can offer general anaesthetic, we've always got options, so we can offer that to you. Some places they can't do. So I've got this thing on the screen, but I don't think you've got it anyway. I'm going to leave it. They can't do. Oh God, we've got some. Oh no, it's okay. They can't do. Yeah, general. So they might be pushing you more to a local, but we can do either. So this is stressful. Mastopexy, is areola reduction included? Yes, it is. So if you have a mastopexy or a breast lift, an areola reduction is part of that. Similarly, another thing that people often ask is is a mastopexy included when you have a breast reduction? So a breast reduction, a mastopexy is included with the breast reduction. You lift the breast and you reduce it for a reduction, and you just lift it with a mastopexy. But when you do a mastopexy, whether or not you ask for it, an areola, you can sort of, the areola is the nipple and the areola are repositioned, and you can make the areola any size you want. We have set markers in theatre. It's normally around 4.5 centimetres for a diameter of an areola, but certainly if your areola is very large, then having an areola reduction can be done on its own. That can be a procedure on its own if that's the only problem, the areola is large. But if you're having a breast lift, an areola reduction is actually part of it. You don't have to ask, or pay more or ask for it anymore. But you might want to have a talk to us about what sort of size you want the areola. Sometimes people will comment and say, look, I'd like my areola to be certain dimensions. You can ask, and we can certainly measure it and make it that dimensions. It probably won't heal in that dimensions, because scar tissue, you can mark something 4 centimetres exactly. 6 months or a year later, you measure it and it's not 4 centimetres, so that's the way the body heals. But you can certainly have input onto what size we make it, and we can certainly talk about that. But it's always difficult to be too specific when you're dealing with the human body and scarring. Animation, right, this has got a big long animation question here. Animation deformity. So animation deformity is when the breast moves when you move your arm, and it occurs in patients who have breast implants underneath the muscle. So when you have a breast implants above or underneath the muscle, there's pros and cons on both. It's not like one's better than the other. And we've got a patient who is considering having breast implants. I think they've been told by one doctor to be over, and then another, I think I said under, and then they're worried because what about all the bad things that will happen if you had them under? Yes, these bad things can happen if you had them under, but there's bad things that can happen if you have them over as well. And so one of the bad things I think they're worried about is animation deformity. So what that means is when you move the muscle, when you move your arm, when you're exercising your arm, obviously your pec major is moving, your pec muscle. If the implant's underneath the pec, sometimes the breast can move, because the breast is actually made up of a lot of the breast is actually made up of implant now, once you've had the implants in. So if the implant moves when your muscle moves, the breast moves. It looks like your breast moves when you're exercising your muscles, when you're at the gym. That feels good. That is something called animation deformity. That's a risk, and this patient's very worried about that, which is reasonable to be worried about it. And the questions that does animation deformity occur all of the time, or just when you work out? Just when you work out. So when you're at rest, you do not have an animation deformity. Sometimes people can twitch their muscles, do sort of party tricks and do twitches and make the breasts move. I don't know if you've seen people do that. That's usually if they're only if they're underneath the muscle. But if you're not, that's obviously twitching your muscles. If you're just at rest and sitting doing nothing, you won't have an animation deformity. So animation deformity only happens when you work out. Is it gradually a permanent feature? Is it gradually, or Oh, yeah, that's right. Does it gradually become a permanent feature, I think, is the question. No, it doesn't gradually become a permanent feature. It is only on movement. It's not all the time. It's only when you move. And it's a risk. It's not a definite. So I'm not saying you will get an animation deformity. It's only a risk. But it's if you do get it, you only get it when you move your muscles, and it doesn't gradually become a permanent feature. No. Would workout force implants apart over time? No. Okay, no. Another risk of having implants under the muscle is they can become apart. So I think the question is, would a workout force the implants apart over time? One risk of having implants under the muscle is they can, as well as animation deformities, you can have a wide cleavage. If you've ever seen a really wide cleavage, and a lot of people worry about this wide cleavage, an abnormally wide cleavage, that's usually when the implants are placed under the muscle and they haven't released the muscle enough medially. You have to really release the muscle here in order to make sure the implants sit together and the muscles don't push the implants apart, because and the reason people get that is because there's a lot of perforating vessels, there's a lot of big blood vessels coming down through the muscle here. So surgeons worry about releasing the muscle here. It's tricky, it's difficult, it's always a bit hairy, as it were, a bit sort of worrying when you're doing the dissection, because there can be some really big blood vessels and they can bleed, they can retract down, they can be quite difficult to control. So as far as the surgical procedure goes, it's something that as we as surgeons need to work hard at to get the cleavage right when we're putting implants underneath the muscle, because we've got to make sure that we release enough of the muscle in order that we don't have it pushing the implants to the side, but we've also got to be a bit careful that we don't damage these big blood vessels, or at least if we do damage the big blood vessels, we can control the bleeding and stop the bleeding. So that is a risk, that the muscles can force the implants apart. It's not something that necessarily that happens over time. It's something that happens if it will happen over time, the first few months or like within the first year of the surgery happening, but it happens if you don't release the muscle enough. So that's why we need to release the muscle enough. But also it is a risk with under the muscle, which is more of a risk than if you have the implants over the muscle. Implants over the muscle is a lot easier to put the implants in the right place, and you don't really tend to get this very wide cleavage. A lot of people worry about wide cleavage, and what I try and point out to people, I show them photos of front views of people with different widths of cleavage, because what we try to do when we do implants is maintain the width of your cleavage, but we enhance it. So some people naturally, they've got a bit of a distance between their breasts, there's a bit of bony sternum palpable between their breasts. Other people haven't got much distance between their breasts sort of start quite close to each other, and whatever the distance is between your breasts before you have surgery will be the same after having surgery, but when you've had surgery the angle is sort of higher, so the cleavage is sort of enhanced, but the width of the cleavage is the same. So that's what we try and do, make the width the same, but it's enhanced. But it's a lot easier to do that when it's on top of the muscle. So yeah, that's another good thing about on top of the muscle. But problem is when you're slim, you might see the implants rippling and all these sorts of things, fill the edges. So that's why under the muscle is good. Balance as everything. So I hope that is that guest appearance tonight by my little son Freddie. So it was nice to see him today. So I'd like to say thank you for Freddie for showing an appearance. Always very welcome on this, to add to the professional nature of the broadcast. So that's that then. Again, thanks to Freddie, thanks to Facebook for bringing me back onto and not keeping me banned for a week. Very, very grateful to you, Facebook. Thank you. And I will make sure that I put in measures to make the photos not offensive or upsetting to people. Not that I've never had any people complain, which is nice. No individuals have complained. It's just Facebook automatically bans it. As soon as you post it, boom, you're banned for a week. That happened to me last week. Imagine my surprise. I thought, oh look, I'm going to give this really good photo which demonstrates all this stuff, and then they banned me, bang. So that was a bit of a douche. But anyway, I'm a professional and I will get over it, and I'm grateful to them for putting me back on, and I'm going to be good from now on. And if I do have to put anything in the bosom area, I will put something over the offending areas. Rambling on now, so that's that. I'm going to check myself out of here, and I hope that's been helpful. If anyone's asked a comment and I haven't seen it, I don't know what is going on, because I've had my masks up and goodness knows what. So I'm going to check myself out of this, and I'm going to go and say to you, next week is not Easter, is it? or is it Easter? I don't think it is. So I'm going to be back. This time next week. I will see you then, and I will be answering your questions then. Happy Tuesday. Thank you for listening and for tuning in. And join me next week for another instalment. Any questions, email me, tweet me, do whatever you want, and I'll be very happy to go over them next week. Signing off. Sayonara. Is that signed off? No. Okay. Hello.